I would like to also welcome people that are online, in addition to everyone here that is here in person. It's my great pleasure to introduce a man who really needs no introduction, Dr. Bill Hogg. He is a clinical investigator here at BRI and is a professor and senior research advisor within the Department of Family Medicine here at the University of Ottawa. And he's also a scientist with the Institute for Clinical Evaluative Sciences, or ISIS. In addition, Dr. Hogg is the president and of the board of directors for NAPCRAG, the North American Primary Care Research Group. Dr. Hogg's research program centers on how to best deliver primary care services to patients. He's the coordinator of the Canadian component of the Quality and Cost of Primary Care Study, which compares performance of the primary care sectors across 34 countries. As PI of the Transformation Research Program, funded by the Canadian Institute of Health Information, he led the development of survey tools now used to measure and compare primary care performance across provinces. And this work will improve accountability, decision-making, and resource allocation, resulting in the enhanced delivery of quality primary care services. So, without further ado, welcome, Doug.
Good morning. Thank you, Doug. We're going to sit through some of this. I hope that's all right. I want to begin by explaining that when I started into medical practice, I was in a rural area of Canada. And that means that everybody knew everything about everybody, including, come on in, David, welcome, including who their family doctors were. There were only 4 of us, so it wasn't that hard. But sometimes, while I was seeing patients in my office, one of my patients might give me a heads up about another patient of mine. So I think the family doctors in the room are going to start to connect with where I'm going with this. So somebody might say to me, Dr. Bill, you know Brian's drinking again. Or when I would go to fill up my truck with gas, of course I went to the gas station that was owned and operated by one of my patients, and that person would come out and we would chat while I was getting gas, and the conversation might happen that would sound a bit like, oh, you know, poor Alice. She's really getting worse, her memory's failing. My wife and my wife's sister are now dropping in on her every day, and they find that sometimes she doesn't have any food in the fridge and that she's not able to keep herself clean. This kind of information was very helpful to me in terms of my efforts to try to provide care to my patients. This sort of intelligence or inside knowledge. But it was also clear that these people were helping each other. It wasn't only that they were helping me to help my patients, they were also helping each other. And this morning, I want you to join me in exploring how and how often patients in our practices help each other. So, whoops. The project is not finished, so if you have any good suggestions, it's not so late that I won't be able to incorporate them. This is the team I'm working with. These people are all in Toronto at ISIS Central. And the money for the analysts' time and so on was provided by the Can-Hart and Transformation Research Programs. These are CIHR-funded research programs. So they're programs, not projects. So it's possible to sort of sequester a little bit of money and go off and do something that you're interested in without having to go and compete in a peer-reviewed situation. And just for your interest, I thought I would share with you that so far we've spent $20,000 on this project. So it's not exactly a huge project in that respect. And I have no conflict of interest to declare. Okay, that didn't work. Okay, so how does this informal network of patients in a family physicians panel get started? How do patients choose their family doctors? So I want to ask you, first, if you have a family doctor, how did you choose this person? Is there anyone who would care to share what happened, what process occurred for them to choose their family doctor?
I asked my friend.
You asked your friend?
Yeah. Who's your family doctor?
Did your friend live near you?
Yeah, I guess at the time, yeah.
Okay. And did you care? Did you sort of say that I want one that's, I prefer a female family doctor?
Yeah.
Okay. So, I think, thank you. How much do I owe you for that? My goodness.
I'm standard.
Yeah, so my talk has exceeded my expectations. I don't know about you. So it's an important decision that people make. If there's a supply problem, and there are, sometimes that's the case, there really aren't, you don't have much choice, then I guess you take whoever will accept you. But for a lot of people, they might spend some time thinking about it, and they might sort of choose in some way. So a female patient might choose, some female patients absolutely prefer to see a female family physician. Or if your maternal language is not English or French, you might think, you might make an effort to find a physician who you can speak to in your own language. So, and this could happen by your consulting with a neighbor, but you might also ask somebody from your community of faith, or even someone from a colleague at work. So there's a whole variety of ways this could happen. But if you look at this picture, I don't actually know what this picture represents. I just stole it off the internet. But to me, it explains what it might look like if you mapped, in a spatial sense, where people live who attend a particular family physician. So the take-home message is that it's not random. Right? People don't go to the phone book and choose their family doctor. If they did, this would just be a series of dots all over the place. But instead, there's been a concentration. And that, you can see how that would happen in Claire's story. You ask a neighbor, there are high levels of satisfaction generally with Canadians, with their family doctors. So they might easily recommend their doctor. And if it connects with, you're wanting a female family physician who speaks Arabic or whatever, then you go, all right. And to the extent that that happens, there'll be clustering, right? Instead of it being random. So I do want to stop for a second and make sure that people have understood this concept, because everything else pretty well stems from that. Okay? All right. So I hope then that you might understand why I was intrigued enough by what's going on here to try to answer these two research questions. The first is essentially looking to see if there's enough variation that I might be able to then answer the second. Okay? So we decided to conduct a cross-sectional study using provincial health administrative data. Most provinces have these. Every time you use your OHIP card, that gets recorded in a database that the government has that ultimately is shared by, is made available to scientists through the Institute of Clinical Evaluative Sciences. So this approach has its advantages in trying to answer these two research questions, because the database includes the 6-digit postal code of every patient. And having the postal codes means that we can calculate the distance between each patient and the closest patients in that family physicians panel in terms of living close to each other. I want to emphasize that I'm interested in the proximity of patients to each other, not the proximity of patients to where the doctor's office is. And of course, there's some data in these databases that allow us to look at outcomes as well. Now, there's some disadvantages as well. Of course, there's no data here about whether these patients know each other and whether they in any way cooperate or support each other. So that's kind of missing. That said, that there is a study that shows that most of the support that people receive when they're ill from members of their social network comes from people who live close to them. So spatial proximity is a not unreasonable metric for social people helping each other, I suggest at least. Okay? Okay. So first we attached every patient in Ontario to his or her family doctor, either by assigning them on the basis of who saw them most often or to whom they were rostered. Then we looked at the range of services billed by those family doctors and excluded anybody who was not providing comprehensive care to their practice. Then we excluded anybody who was in a really remote or rural situation, just because to make it less complicated. And finally, we tried to drive it so that we were only looking at full-time physicians, and we did that by insisting that they had a panel size between 1,300 and 2,000 patients. So that's our study population, and there are 1,710 family physicians who practicing in Ontario who meet that criteria, and almost 3 million patients. So step 2 is for each of these 1,710 physicians, we calculated the geospatial proximity of their patients one to another. Okay? So think of, we'll choose doctor number 1. Consider that this doctor might have 1,500 patients in his or her panel. We start with patient number 1, and we measure the distance to the other 1,499 patients, and then we only take the 10 that are closest. And we actually, they cannot have the identical postal code because I'm trying to distinguish between family members and near neighbors. It's not perfect, but it's not bad. Okay? So the sum of those 10, the distances to those 10 people is the metric that I refer to as that individual's spatial proximity index or something like that. Okay? Then we go on for the other 1,499 patients in this panel. We do the same thing and we average it, and we get a spatial proximity index for the panel of patients for that doctor. Anybody got any questions about that? Please ask me to say it again if you don't understand, because you won't get much more out of this if you don't understand this. Okay. All right. Good. Anyone on the phone or anything that wants me to clarify? Okay, so the answer to the first research question is yes, there is variability. What we did was we divided the 1,710 family doctors into quintiles based on how close their patients live to other patients in the panel. So in the first 20% of the 1,710 family doctors, these are the ones that had patients living most closely to each other. And then it moves up until you get to the 5th quintile, each quintile clearly having 20%. All right? And you can see that there's a substantive difference. All right? There's a 300% difference in terms of how clustered the patients are. Okay, well, let's kind of look at this a little bit. We looked for the associations with physician characteristics in the practice, and I think I can convince you that what we got will make sense to Claire Lynn, all right? Because if you prefer a female physician and you make that happen, if the physician is female, these are physician characteristics, okay? So the mechanism is probably female patients choosing to go to the female doctor. And when that happens, and they do it based on a discussion with a neighbor or a friend who's a neighbor, then the distribution spatially will not be as random, and there will be more clustering. People will live closer together because the way they chose the doctor was based on the advice of a neighbor. Okay? Similarly, if you're interested in having a doctor that might speak your language, whether the physician graduated in Canada at a Canadian medical school or is a foreign medical graduate, that's probably a surrogate for that person's ability to speak another language. So, and if that's the case, in those practices, the patients live closer to each other. Now that's absolutely my experience. When I began, I was saying that I practiced in a small town. This stuff is pretty visible in a small place because of everybody knowing everything. And when the first female family physician that joined our group, it was apparent right away that there were lots of female patients that switched and went to that new female physician instead. And similarly, we had a francophone partner, and there were lots of patients who preferred to deal with him rather than struggle through my fractured French. So it just kind of fits, I think, with why I was looking into this in the first place. Okay, we also found that sicker people were more likely to be in these close proximity practices. Can anybody suggest why sicker people might be more likely to end up in a close proximity practice?
Neighborhood characteristics.
What do you mean?
Related to like one area that might have lower socioeconomic status. So there's more similarity between sort of the people.
Yes, that could happen. But if you control for it, it still is the case. So I was thinking that and of course I don't know, but I'm thinking that if you're sicker, we did this through health admin data, so it's all the RUBs and the comorbidity indices and things like that. If you're sicker, it might be more important to you. The whole business about choosing your doctor might be more important to you than a 22-year-old male who doesn't think he's ever going to get sick. So you might spend more of an effort. You might consult with your neighbors and so on, rather than it's just a little bit less random, and that might cause some greater proximity. Yes, David?
Is it possible that there are environmental effects that we can't control for? We know that you're more likely to have dementia around highways now. And that's not something we necessarily can measure yet.
I can't remember. Good question.
They would control for if these people chose their family doctor after they had been sicker, or was it actually that they all had a bad family doctor?
That's true. Yeah, that could be it.
Preventative medicine that they all.
Yeah. That's it. We're bad for people's health. Okay. Well, another characteristic that we found was there were fewer smokers in close proximity practices. And this one actually puzzled me initially, but I have found an article that I think might explain this. And so I've shared it with you in bold print here. So Christakis and Fowler have shown that smoking cessation spreads in social networks. To quote them, people are connected, and so is their health. Health interventions to encourage people to quit smoking might be more cost-effective than initially supposed, since health improvements in one person might spread to others. Cessation of smoking in one person appears to be highly relevant to the smoking behavior of others nearby in their social networks. So, if that's true, I think it makes sense that this would concentrate in closer proximity practices. So if you just humor me and assume for a minute that family doctors are somewhat effective in helping people quit smoking, but that the family doctors in the 5 quintiles are equally effective. And they're equally motivated and they work just as hard at this. But the family doctors in the 1st quintile, the ones whose patients live close to each other, when they succeed, there will be a ripple effect that goes further because that social network is more dense. Okay, and over time, there will be less smoking in those practices. So I think this is kind of important because it's independent of the skill, the motivation, or the training of the family doctor. So it's starting, for me, to get interesting. And I will again say that this kind of resonates with my own personal experience. Maybe I couldn't see it with respect to smoking, but I saw it with respect to alcoholism. And I had a very severe alcoholic in my practice who miraculously managed to turn his life around and never drank again. And this was really disturbing to the other alcoholics in my practice because they had somehow maintained their denial of how sick they were by looking at my patient, and when they could no longer say, no, there's an alcoholic, they had to, I don't know what the mechanism is exactly, but there was no doubt that there were ripples that went out in a way that is kind of consistent with this whole social network thing that we're living with LinkedIn and Facebook and all throughout our lives. Okay, so let's move towards the second research question. Does this in any way matter to people's health? So the primary outcome in this study was a cardiovascular event in a recent 5-year period. And by cardiovascular event, I mean someone having been admitted to hospital for an acute myocardial infarction or a stroke, or having died of cardiovascular disease. Well, this is a great outcome, partly because one of the groups, the Canhart people, had already done all the work and created the definitions and the cohort, but it didn't cost anything. But also because it's common, which clearly is going to help with any statistics that might happen here. Someone dies every 7 minutes in Canada of an acute MI or a stroke. Okay, so does it matter? The answer is yes, it matters, and it matters a lot. And you want to be looking at this column here, okay? These are the adjusted regression results. For those on the phone, it's the column on the far right that's in blue. And the reference group is the group with the closest, the quintile with the closest spatial proximity of patients. And you can see that it progresses up in a gradient, progressive gradient, to demonstrate a 23% improvement in the low spatial proximity group to the highest quintile. Between those 2 quintiles, there's a 23% difference in the adjusted model. And we adjusted for a number of patient factors, a number of physician factors, traditional cardiovascular risk factors, the distance between where the patients lived and where the doctor's office was located. Okay, so socioeconomic class, total cholesterol, LDL cholesterol, hypertension, diabetes, you name it. Spent all summer trying to disprove this result.
Did you adjust for rural versus urban?
We did a sensitivity analysis, which showed that the effect was slightly greater. We were kind of worried that Toronto would, is this a Toronto effect? Okay,
Or even,
so,
my thinking is, you could have the same proximity in in an urban setting, and people don't know each other, don't help each other.
yeah,
And in a rural setting, they all know each other and all helping each
That's
other. So if you control for rural versus urban, then you would hopefully
Yes.
be able to somewhat tease that out. But
we,
So
we have shown that the effect is greater in cities the size of Ottawa, Hamilton, London, places like that, than in Toronto. But the effect is there throughout the rurality sensitivity. But I do say to you that whenever the doctor's office was located in a village with less than 10,000 people, we excluded them. So we did not look at this in the more sort of
so you didn't have any
remote
zero
area.
postal codes, basically. Postal codes ending in 0 are,
Oh, I don't know.
rural?
Is that the way it
yeah.
works? Yeah.
So if it ends with a 0, it's
Okay.
considered rural by Post Canada. And it's I think it's even below
That may-
5,000 inhabitants
Yeah, I'm not
or
quite
something.
sure how they did
There's
it,
a cutoff.
actually. Yeah.
Just to add to the rurality though too, you said I think you excluded them because if you look at the rural postal codes, they're way too big. So one postal code is for all of like Renfrew, Armstrong, so you wouldn't be able to tease out
Yeah.
the aspect that you're looking at.
It's a limitation that we have not looked at it more extreme.
So you really
rural
looked in
cities.
in urban populations above 10,000.
Yes.
Okay,
So we have, I think, demonstrated that there is an association between closer spatial proximity and better health. It's an association, and I'm going to spend the next few minutes talking around the subject about whether it's an association or whether it's causal. There will never be a randomized controlled trial that's going to settle this, okay? So we won't know. But I want you, in the next few minutes, to try to think with me about whether this is a fairly meaningless association or whether, in fact, people may be helping each other in some fashion or other. So let's first look at the idea that it's an association. It may be that there is a selection bias that favors individuals who better look after themselves. People who care enough to make an effort to go out and get the kind of family doctor they want may care more about their health, and they may look after themselves better, and that may be the reason why they're showing better health outcomes. It may have nothing to do with their proximity to their neighbors. All right, that's, I think, possible, for sure. Or it could be that people who are able to find the kind of family physician they prefer, like their problem-solving skills are good generally at solving problems, and including health problems. But I would point out that when we look at socioeconomic status, this effect does not go away. So it's not that their problem skills make them richer. Or it may be the way in which they solve problems. Maybe it's because they talk to a friend, they consult, and their method or their approach to solving problems wouldn't just be around this, it would be much more general. So they are, by their personality types, people who talk to other people and seek advice. And so maybe those people have a more robust social network that looks after them when they get sick. And it's not just their neighbors in the physician's panel that help them. It's more general than that. It's all sorts of people, because that's their problem-solving approach. And as you know, social connectedness is very important in terms of protecting a person's health, and certainly could explain the kind of magnitude of effect that we're talking about here. But I will share with you that the magnitude of the effect kind of blew me away when I first saw it, because in most of the research we do in clinical medicine, like, we're delighted if we get a 5% difference, right? We don't normally wake up to this kind of a result. So, so you do have to look, I think, to understand what might be going on here by looking at those determinants of health that are really strong, stronger than how effective your family doctor is, probably. Okay, so that's the story around whether this might be an association. But let's consider the possibility that it might be causal. And let's face it, that's why I was looking into this in the first place. It was because of my experience and practice led me to believe that people were helping each other. And I shared 2 examples with you, but I know every family doctor in this room has thought of a couple more. All right, so there's maybe something going on there. Okay, well, if you're trying to impute causality, there's a wonderful article by Hill that has describes the characteristics that can encourage you to think it might be causal. And the first is the magnitude of the effect. Well, we got a big effect. The second one is that it is a progressive linear gradient.
So what was it, sorry, I can't see from back here, but what was the effect?
Okay, the unadjusted numbers go through, okay, show a 35% difference, but once you throw in all these different things into your model, you get a difference of 23% between the 5th quintile and the reference quintile. And it goes up from 1 to 1.04 to 1.05 to 1.14.
Are you sure? So I just looked, that's not really like a big effect. I'm not sure what definitions you're using just to call that a big effect. That's a significant effect, and I think it's an important effect. But you're just kind of, you're using double causation now, so I think I just want to be careful you're defining effect size properly, because I just think that you can, that would, big effect sizes really make us think causation, because it's like so big that this is probably going to take out any kind of other problems. But when it's just a smaller effect sizes, we have to worry about confounding variables. That's all. I'm just bringing this up.
Yeah.
It's an important first step.
So how big is big then? Like what?
5 to 10 times larger.
Okay, right. So it just dwarfs it, and everybody.
2 to 5 is moderate. So 2 to 5 times bigger, and you won't be getting close to that. Maybe that's a really important effect size. But really big, when they really want to want to hammer causation, and that really makes us feel more confident. But that's super big, and that happens like rarely.
Okay.
Just, by the way, I'm not saying.
No, I'm persuaded by what you say. That's good. Good. Thank you. Okay. Now the other way that would help you impute causality would be if there was a plausible mechanism to explain how it might happen. Okay. And so let's talk about that for a minute. Okay, so Umberson et al. Have demonstrated that relationships shape health outcomes throughout the life course and have a cumulative impact on health over time. So it could be that maybe a neighbor helping once in a while over a long period of time might benefit somebody when they're sick. We found in the high proximity panels that patients saw their family doctor on average 1 time more per year. Maybe people give rides to each other. And again, this links with what I'm doing. When you were working in fee-for-service and somebody canceled their appointment in the middle of the day when you're roaring through and you're going full speed, it's one thing if one person cancels, but if 3 or 4 cancel all in a row, you sit there twiddling your thumbs, and yet you're still paying for your office staff and everything else. So you notice it. Well, what I would notice is they weren't always in the same family, but often they were neighbors. So they were carpooling to come in and see me. And maybe they're having access to better care. We saw that in the close proximity panels, people were more likely to have a periodic health exam, were more likely to have been screened for cholesterol, and more likely to have been prescribed a statin. Okay, now, I think it's reasonable to suggest there might be some other possible mechanisms at play as well. One would be that compliance with treatment is better and the placebo effect is greater when there's greater trust between the provider and the patient. And when somebody has recommended their doctor to you and you end up going to that physician, you might have a better start and ultimately a better relationship. But a probably more reasonable hypothesis revolves around the diffusion of information in social networks. When people know each other clearly, information is going to diffuse better. When they live close to each other, it's going to diffuse better, and particularly for the kinds of things that family doctors deal with, which are common. So a kind of rippling effect around information. And finally, the other mechanism would be social isolation. When a neighbor brings a warm casserole over or whatever because you're not feeling well, there's no doubt that that helps people get better. Cardiovascular disease happens by 1,000 cuts. It's these stresses over a lifetime that lead to the acute event of a blockage of the artery. So a little help over many years, potentially having a big effect. Okay.
Bill?
Yeah.
Did you look at, or is it possible to look at, I'm wondering, like the emergency response, sort of the idea that if you were unwell, you know, in your proximity to neighbor, they're going to call the ambulance or assist you if you're in a bit of a crisis?
No, we didn't, but I think maybe we could, because the ambulance, the calling of an ambulance is available in the database.
Mm-hmm.
Very interesting idea. And time to, well, it's not so much whether you survive the event, it's whether or not, because we included you, whether you died or survived, right? But it's an interesting idea.
Wow.
So maybe I missed something at the beginning, but the basis for the cohort formation was non-selective to start with, and then you looked at cardiovascular outcomes, or was this a sort of a pre-selected cohort of people who had already some underlying issue going on? That wasn't.
No, sorry.
So it's a general unselected.
The outcome was the algorithms that coded for the outcome I took from a different study.
Okay, but it was defining what? Cardiovascular disease outcomes?
Yes, it was
Okay.
an event, a
Yeah, okay.
cardiovascular event in a recent 5-year period.
Okay. So that's
Or
your,
either having had an acute MI or stroke
Yeah.
and being hospitalized for that,
Yeah,
okay?
yeah.
Or having died
Okay.
from it.
Okay, but there was no pre-selection at the start. We're
No.
not looking at an already sort of
No, we didn't confine our study
defined
panel.
cohort or
Yeah.
something. Okay.
Okay, all right. So, yeah,
So I was thinking about how in like very disadvantaged African communities that these people have no social network, no social assistance. There's nothing to support them, when things are going bad. And so it's their community, and it's their extended family and community that actually keeps them alive.
mm-hmm.
And so but unfortunately, it actually has a good and bad side of it. So if you actually start to make a lot of money, you have to share your money with your whole community. If you ever go to university, it almost takes you away from your community because you can't fit in again. So unfortunately, there's really these negative sides of having the community support structure. So a lot of people, we had this in Black Nova Scotians, and it's been proven they cannot leave their community. It's just such a strong social net. So the reason I just mentioned this is a little bit like you're talking here, is that in our new modern world, we have incredible mobility. I mean, the Globe and Mail showed, I think we're up to 22, 23% foreign-born people in Canada now. You know, and even, so people are moving around, and so we have this kind of, this is the African situation, which is kind of like maybe traditional, and that's how it worked, for hundreds of years. And now we have a little bit, so your project is very ambitious in terms of understanding the modern mobile communities of how people are helping or hurting each other. So I think there's going to be both sides happening. So often, you might help, but you also might, people might drink more because they're together more. I don't know.
So I've just got one eye on the clock, so I'm not going to spend too much time on this, but we found that if you were poor, you were more likely to be in a close proximity network. So maybe that fits or not with what you're saying.
And you're also more likely not to have a car to get to your appointments.
True.
Right?
True. Yeah. Okay, so I'm going to forge ahead here because I'm the warm-up act. You're getting ready. All right. Look, obviously, one study is not going to change policy or practice, but I do want to make the point that this is actionable. So if it turns out that others, reinforce this work, and doctors come to believe that this is important, and an aspect of their influence or effectiveness that is important, there are things they can do about it that cost almost nothing. So an example would be, and I'm sure it's already the case, that doctors tend to be more likely to, as their practices get more or less full, to accept somebody if that person is referred by somebody they already know. Well, they could make a rule out of that and insist on it. And so could government programs that attach orphan patients to family doctors and so on. You could just kind of nudge it. Beyond that, there's some pretty obvious policy solutions as well, but they depend a little bit on the mechanism. So this is assuming it's causal, all right, which we don't know. But if the mechanism was better diffusion of information, there's some pretty easy things that doctors could do now that we're all computerized to send good quality information out in an outreach program to patients. If the mechanism is, if the mechanism is improved social support, there are also things that could be done to facilitate patients who are neighbors of each other to help each other more frequently. So at the time that new patients register to practice, you get all the permissions that you need, and then you set up programs that assist neighbors to kind of cooperate. Like you might have an exercise program or something that's in one of those little clusters. And looking at Claire, the Stanford approach in terms of patient self-help groups, things could be directed a little bit to move in this direction. Okay, so finally, I want to say that I think these findings might offer an additional mechanism to explain the primary care paradox, which I have written in front of you on the slides. And I say this because I think it is more likely for a patient in a family physician's panel to live near another patient in that practice than it is for a patient of a specialist physician to live near another patient of that specialist physician. And I say that because of the way people get sent to specialists. It's often the family doctors from a wide area that are sending people to see a specialist who, by definition, has a focused area of practice. people clearly have more choice in choosing their family doctor. In Ottawa, we even have services that push the referral to the next available specialist. So inevitably, family doctors are going to have more dense networks of their patients than specialists. And to the extent that information flows better through a more dense proximal network, there would be an advantage for the family doctor. It's also because the problems we deal with are more common, and so they would also ripple out further in a social network sense. So let me give you a specific example, and I'm almost done. When you see a patient in your office, you may be, without realizing it, helping others in your practice and in the broader community around you, not necessarily in your practice. So if you see a 14-year-old girl who comes in because she wants birth control, and during that meeting, you successfully reassure her that her mother and father aren't going to find out that you've written this prescription, she goes home and might easily end up talking to a friend who would then get care, who otherwise might not have got it, and an unwanted pregnancy is avoided. So you and your patient have helped somebody who's not even in your practice, okay? Which is where this paradox starts to sound familiar. So similarly, most social support comes from people who live nearby, and spatially dense networks convey a natural and inevitable advantage in that respect. So no doubt, it helps family doctors to care for their patients when they're smart, well-trained, and highly motivated, and work hard. But it appears that simply by being a generalist, they also help their patients and indeed the entire community in which they work. So this previously undescribed part of their effectiveness appears to come through an informal network of patients that help each other and that I posit are able to help each other as effectively as they are because of the density of their connections to each other, and that that generalist physicians look after common problems. So it is a result of their being a generalist. It is intrinsic to the generalist approach and is old as family practice itself. Thank you.
I have a couple minutes for questions.
Okay. Yes, at the back.
I'm wondering if you might be losing some information by not counting people with identical postal codes. Because I'm thinking, I live in an apartment building, so
Yeah.
when I'm asked about my neighbors, I think of the other people in the building. And especially if you're using data from Toronto with those high-rise buildings, if I talk to my neighbors about my family doctors, we all have the same postal code, right?
You're absolutely right.
Right, and then,
Yeah.
did you mention you did to avoid double counting family members? And
Absolutely, and we're losing in a similar way. I totally agree with that this is a weakness of our approach. You're also losing the fact that not all family members are co-located. You know, your sister could live down the street. And so we have not really successfully been able, using this data, to distinguish between family and neighbors.
But you could do sensitivity analysis including the same postal code and see how your results change.
Yeah, we were going to do exactly that, and debated this at length and decided not to. I forget, it might have been just how much it was going to cost or something. Yeah. Yeah. Camilla.
I find this really interesting in the context of the pay-for-performance landscape. So
Yes.
there's a lot of literature trying to study whether or not pay-for-performance actually improves, whatever outcomes or proxy outcomes are being used. And most of the data I've seen has been inconclusive, and that pay-for-performance doesn't seem to affect, how many patients get an FOBT or a mammogram and that sort of thing. And the theories about what underlies this seem to focus mainly on the physician side, and that physicians, don't really change the way that they practice, and in response to incentives and are already highly motivated to provide that type of care, but maybe this explains it in a different way in terms of the patient side of things, in which case that further makes the case for why pay-for-performance perhaps does not really fit with healthcare and primary healthcare in particular.
So, thank you for your comment. It takes me back to the place in my presentation where we were debating whether this is an association or a cause. And if you believe that it's an association, okay, it still has some relevance. And your example would be right on for that, okay? I mean, let's never mind the fact that it might actually be causal and we could harness it. If it's true that you're measuring performance for people of physicians and you intend to pay them differently or incentivize them to, by rewarding higher quality outcomes, and that outcome is happening for a reason that has nothing to do with how clever and hardworking they are, that's not fair, right? So everybody, I think, would agree that if you're going to pay physicians based on the quality of their patients' outcomes, that you would want to adjust for socioeconomic status. Otherwise, it would be totally unfair. No one would ever go work in a poor neighborhood. Similarly, you might want to adjust for how complex the patient populations are. Right? But I guess we're saying you might want to adjust for this too. Right? Yeah, David. Oh, I'm sorry. David and then...
Super important, interesting finding, especially if I understood correctly that the clustered group is actually sicker at baseline.
Yes. A little bit.
A little bit sicker. So I'm wondering about clustering around hospitals. I have a number of patients who like to be close to a hospital. As you know, I used to work at the Civic with you, and then I moved to Bruyère, and a bunch of patients didn't move with my practice because they felt very attached to the Civic. So just like Claire's wondering about ambulance response times, I think it'd be pretty easy to check that out.
Yeah. Good point. David and I worked on a study together that showed that female family physicians have better outcomes than male family physicians. And we looked at everything to try to understand how this could possibly be true.
Trying to disprove it.
It wasn't the fact that they tend to be younger and graduated more recently and stuff like that. But you know what? It may be, this might have an effect, right? And so some of it also, I think, even if it's just an association, kind of a hidden selection bias that's happening in the background, it may have to go back and redo some of the work we've been doing to understand it. I think there was, that's it?
That's all the time we have. If you have any questions, please see us, Bill, during the break. We're going to be starting up 25 to sharp.
Thank you.
Thanks, Bill.